Esophagoplasty, plastic repair or reconstruction, cervical approach, without repair of tracheoesophageal fistula. With repair of tracheoesophageal fistula, the physician repairs a defect in the esophagus using plastic repair or reconstruction. The physician makes a lateral neck incision to access the esophagus. The defect is identified and repaired. In 43305, the physician also transects the tracheoesophageal fistula. The physician closes the tracheal opening and repairs the esophagus. The incision is sutured in layers. Esophagoplasty, plastic repair or reconstruction, thoracic approach, without repair of tracheoesophageal fistula. With repair of tracheoesophageal fistula, the physician repairs a defect in the esophagus using plastic repair or reconstruction. The physician makes a thoracic incision to access the esophagus. In 43310, the defect is identified and repaired. In 43312, the physician also transects the tracheoesophageal fistula. The physician closes the tracheal opening and repairs the esophagus. The incision is sutured in layers. Esophagoplasty for congenital defect, plastic repair or reconstruction, thoracic approach, without repair of congenital tracheoesophageal fistula. With repair of congenital tracheoesophageal fistula, the patient is placed in the supine position with the left shoulder elevated and the head extended. A cervical incision is made along the anterior margin of the left sternocleidomastoid muscle, which is retracted laterally. The sternothyroid and sternohyoid muscles are divided, as well as for the branches of the ansa hypoglossi. The inferior pole of the thyroid gland is mobilized and retracted anteriorly. A dissection plane between the trachea and esophagus at the inlet of the thorax can be approached, entered, and dissected. The tracheal and esophageal defects are closed primarily. If the defect is large, a pedicle muscle patch is required to replace the tracheal defect. 43314. A denervate and vascularized muscle pedicle is sutured to loose areolar tissue adjacent to the trachea on the opposite side. The esophagus is closed in 2 layers. The trachea is closed in 1 layer, with sufficient sutures to make an airtight closure. Esophagogastrostomy, cardioplasty, with or without vagotomy and pyloroplasty, transabdominal or transthoracic approach. The physician performs a plastic repair of the lower esophagus where it joins the upper area, cardia, of the stomach. The physician may also transect the vagus nerve and or enlarge the pylorus, the distal portion of the stomach. The physician accesses the esophagus through an upper abdominal or lateral thoracic incision. The diseased portion of the esophagus is resected. An anastomosis between the esophageal stump and the cardiac portion of the stomach is created. If the lesion is secondary to acid reflux, a vagotomy may be performed. The anterior and posterior trunks of the vagus nerve are transected to decrease acid production. If the gastric outlet area is decreased, a pyloroplasty may be performed to enlarge the pylorus. The incision is repaired in sutured layers. Esophagogastric fundoplasty, with fundic patch, Thalnissen procedure. The physician pulls up part of the gastric fundus to cover the affected distal esophagus. A bougie, dilating instrument, is placed in the distal esophagus to maintain the esophageal opening. The physician accesses the esophagus and stomach through a transverse abdominal incision. The physician picks up the stomach 1 cm below the gastroesophageal (GE) junction and attaches it 1 cm above the GE junction. This fundic patch is sutured to the esophagus. Next, a Nissen fundoplication is performed by wrapping the rest of the fundus around the esophagus and suturing it into place. The incision is sutured in layers. Esophagogastric fundoplasty partial or complete, laparotomy. Thoracotomy.